Good morning. This integrity presentation focuses on care of the patient with a gastrointestinal disorder. We'll begin by looking at those organs that are involved in the gastrointestinal or GI system. The primary GI organs include the mouth, where mastication or chewing begins once a food substance is allowed to enter. Excuse me. The esophagus, the stomach, small intestines, large intestines, colon, rectum, and then food liquids are expelled through the anus. Accessory GI organs include the liver, gallbladder, and pancreas. And here you have a pictorial illustration of each of those organs and their location sites. You should review your anatomy and physiology as indicated on your learning objectives. Assessment of the GI system involves obtaining a chief complaints. The variables that to be examined include asking the person to describe the problem that they are experiencing, such as a stomach ache. The severity, is it sharp, dull, aching? The onset, when it began. The course, how long it has been in place. Characteristics, what other accompanying signs and symptoms are being experienced, such as nausea, vomiting, diarrhea, constipation. Precipitating and alleviating factors, such as those items that may precipitate stomach pain may be eating chocolates, stretching or bending. And alleviating factor examples, applying a warm compress if indicated, or lying on their side, resting, taking pain medications, various analgesics that they may receive over the counter. Some typical symptoms associated with gastrointestinal disorders include indigestion, flatus, constipation, pain, reflux, nausea or vomiting, and if they have vomiting, you want to assess the color of the vomitus. Coffee ground emesis occurs with gastric bleeding. The person may have distension if they are not digesting the foods properly, and you want to assess the abdominal girth by putting a tape measure around it, and you also want to make sure that you palpate the abdomen and listen to the bowel sounds. Medications that are commonly used include aspirin or nonsteroidal anti-inflammatory drugs, as these both can cause bleeding. Laxatives to relieve constipation. However, laxatives can become addictive and can accentuate the problem. Vitamins can cause problems. Antacids can be used to help alleviate distension. It can also help alleviate gas. And vitamins, going back to vitamins, they may be used to help supplement some of the nutrients that have not been received because the person may not be eating appropriately, or because they are experiencing diarrhea and losing their vitamins sources from various foods, or they may not be able to tolerate eating various foods and as a result need those vitamins as supplements. Narcotics tend to cause a sluggishness or decrease in the peristaltic activity, which can result in constipation. And other medications will be explored during the various topics of presentation. Nutritional assessment, you want to evaluate the type of diet or foods that the person eats. Are they eating spicy foods, a lot of liquids, a lot of high-fat food contents? The routines, how often do they eat? what type of activities are they engaged in when they are eating. A lot of times, if we are very active, we tend to eat on the go and eat a lot of fast foods, or we are not chewing our food appropriately. You want to assess the weight to see if it's in proportion to their height and determine if they are overweight or underweight. Overall nourishment. You can look at the person and do a nutritional assessment of them physically to determine what their status is. How chief complaint may affect their nutritional status. If the person has, for instance, diarrhea, they're not going to be able to tolerate eating foods, and as a result, they may end up becoming slightly dehydrated, have an alteration in their nutritional status as a result of not eating properly. If they are in a lot of pain, they're not going to take the time most often to eat effectively. So you want to look at each chief complaint and determine how the chief complaints and the variables impacted by that chief complaint will affect their nutritional assessment status. The physical exam, you're going to obtain a height and weight. Look at their oral cavity so that you can assess their teeth, their gums. Sometimes if teeth are missing or loosened, it will impact their ability to chew certain types of foods that they may be trying to eat. If they have cavities, if they're eating foods that can aggravate those cavities, such as cold food items, you want to evaluate that and see about them having a referral. Abdomen. Assess the status of the abdomen, listening for vowel sounds. The girth, determining whether there is pain in the abdomen, and as you are aware, if the person has pain, you want to assess that area last when it comes to palpation, because you don't want to aggravate the person. Diagnostic tests, upper GI series, and I want you to look up each test and read more detailed information as you go through your text and other resources. A barium swallow is an X-ray of the lower esophagus, stomach, and duodenum. They use barium sulfate as contrast medium, and a barium swallow can be used to detect tumors and ulcers that are located in the esophagus, stomach, or duodenum. You always want to assess whether or not a person has an allergic reaction to any substance that's going to be used as a contrast medium. In preparation for the GI series, the person should be NPO by midnight. Explain need to expel barium post-procedure, and this can be done by increasing their fluids and giving them milk of magnesia post-procedure. The next test, esophagogastroduodenoscopy, endoscopy, and gastroscopy. These tests can be used as direct visualization of the upper GI tract by long fiber optic flexible scope utilized. They can visualize tumors, varices, any inflammation, hiatal hernias, polyps, ulcers, H.PYLORI bacteria, strictures, and obstructions that may be present. And if a person has an obstruction, you will see possibly distension of the abdomen because the food and liquid content is not being allowed to flow appropriately through the GI system. These tests can also be used to remove polyps during the procedure, take biopsies, coagulate sources of GI bleeding, and for sclerotherapy with esophageal varices. An endoscopy is used to remove polyps, can be used to coagulate bleeding, sclerotherapy of the varices, dilation of esophagus, to collect tissue samples for biopsy purposes, and this person following is at risk for bleeding, so you need to observe them closely and monitor their vital signs. Patient preparation, NPO, the administration of IV fluids and medications. They need to sign a consent form, and Valium or Versed can be given for conscious sedation and help the person to relax. Atropine is administered to decrease the risk of aspiration by drying secretion and decreasing the amount of secretions. The procedure. A local anesthetic to the throat is administered. Cardiac monitoring is done because they may have arrhythmias to occur. Pulse oximetry is done to monitor the pulse oxygen saturation. The person is positioned on their left side, head a bit elevated to help reduce aspiration. Tube is placed through the mouth into the esophagus, head bent forward. And as needed, meds can be given to the patient as ordered. Air is instilled to flatten the tissue folds. Water or normal saline is used to rinse the lens or a lesion. Suctioning is done to remove any secretions and reduce the risk of aspiration. The patient should be informed that they will feel some pressure. Post-procedure care. You want to monitor the vital signs and be sure to report abnormal findings. You should always know the baseline vital signs prior to them going into the procedure and then monitor them closely afterwards. Observe for respiratory problems. Food and fluids are withheld until the gag reflex returns, and the patient should be informed that they will have a sore throat. And belching can occur because of the air introduction, which leads to gas buildup. You want to observe for signs of perforation that may occur during the procedure. These include a complaint of severe pain in their throat, neck, stomach, back, and shoulders, an elevated temperature, blood and vomitus, or in the stool. And you may have to obtain a guaiac if it's not frank, bright red bleeding, but most often it can be. Another test is the gastric analysis. It's used to measure hydrochloric acid and peptic content. The person is NPO 12 hours prior to the test. The NG tube is in place and connected to low wall suction. Samples are collected every 15 minutes for 1 hour. The person received no anticholinergic medications 24 hours prior, and I want you to tell me why. No smoking isn't allowed. NG2 can be removed following the test. NG2 that was removed would be inserted, of course. Stomach contents are aspirated. Specimens are labeled and sent to the lab. Remove the tube, and the person can eat according to the orders that are written. Fractured mandible. It's the most common facial fracture. First priority, assessment of airway. It usually requires fixed occlusion for 6 to 10 weeks to allow teeth to heal in proper alignment. You want to take into consideration their dietary intake. And often this person can tolerate liquids or soft food items. Remember, because of the fracture, they won't be able to move their jaw effectively. And you want to assess their nutritional status on a regular basis. Stomatitis is a painful condition in which there are open ulcerations of the oral mucosa. There's a break in mucosa predisposing the patient to infections. Therefore, you need to observe their oral mucosa for signs and symptoms of infection and monitor laboratory results that are relevant. Stomatitis may be due to herpes simplex type 1, candidiasis, chemotherapy or radiation, which weakens our immune system, and other opportunistic infections such as MRSA, HIV positive patients, AIDS patients, and others who have weakened immune system. Neoplasms, or cancers of the mouth, is the next focus. There's a high morbidity and mortality associated with neoplasms of the mouth unless found early. It is important to stress to the patient when they see any changes to seek medical advice as soon as possible. Pathophysiology associated with neoplasms include cancers of the mouth, lip, tongue, or pharynx. Usually the condition is asymptomatic during the early stages. Subsequently, inflamed areas appear and the person has non-healing lesions with irregular, ill-defined borders. And the conditions are often painless, which again means that a lot of times people will not tend to note any change in their mouth because they don't feel it in pain, but they should inspect their mouths. Late cancers associated with neoplasms of the mouth result in deep ulcers. They involve the tongue or pharynx, mandible, and maxilla. The most frequent type is caused by squamous cell carcinoma. Or cancers, here we have two pictorial illustrations. Symptoms: late, the person has difficulty speaking, swallowing, or chewing. There are swollen lymph nodes, blood-tinged sputum. Any oral lesion that does not heal within 2 weeks is suspect of being cancerous. Treatment involves staging the tumor to determine the extent of involvement. You want to eliminate causative factors for the cancer or the tumor that's in place. Radiation is administered to kill or slow the growth of the tumor. Chemotherapy is administered to kill tumors, and the person may have to have a radical neck resection to remove the tumor. And I want you to read in detail about radical neck resections. Esophageal cancer is a relatively uncommon problem in the United States. If the person develops it, the prognosis is poor and they will most likely die. There have been recent improvements in detection and treatment which have increased survival rates. A risk factor is Barrett's esophagitis, which is a complication of GERD, a gastroesophageal reflux disease. We will talk about Barrett's esophagitis in class. 2/3 of this type cancer is caused by squamous cell carcinoma, second most common adenocarcinoma. Risk factors: alcohol use, tobacco, and reflux esophagitis. It's more common in men ages 55 to 70 years of age. Symptoms include dysphagia, which is the most common symptoms, weight loss, regurgitation, and aspiration pneumonitis, which we have talked about in the past. Treatment includes staging of the tumor, again to determine the extent of involvement, the administration of chemotherapy, and/or radiation, and surgery. Oftentimes, though, treatment is palliative, making the patient comfortable, helping to alleviate pain. Surgical procedures. Esophagectomy involves removal of the esophagus and replacement with a graft. Esophagogastrostomy is another surgical procedure which involves resection of the diseased part and attachment of remaining esophagus to the stomach. Esophagoenteroscopy It involves replacement of the diseased part with segment of the colon. Palliative procedures, dilation of the esophagus to make it easier for food and placement of tubes. Stent in the esophagus to expand or dilate it. Laser treatment, radiation therapy, chemotherapy. Stomach cancer. Risk factors for stomach cancer include H. pylori infection, pernicious anemia, exposure to chemicals in the environment, diet, those high in sodium, nitrates, which can be found in smoked foods and preservatives, and the prognosis is poor. Symptoms are vague in the early stage. The person has a feeling of fullness after eating, vomiting after a meal, hematemesis or melanoma, anorexia, weight loss, anemia, and pain is present in the late stage. You can see how easily these symptoms can result in the person not being diagnosed in a timely manner because they are so vague. Late symptoms include the problem often metastasizing to the liver, pancreas, colon, and regional lymph nodes with organ system involvement. Distant metastasis to the lungs and bones. There's a 5% chance of 5-year survival rate. Treatment, partial or total gastrectomy, chemotherapy with the use of 5-FU, deoxyribosine, palliative radiation for comfort measures. The next condition, achalasia, absence of peristalsis in the lower 2/3 of the esophagus occurs. Results in accumulation of food and fluid in lower esophagus and esophageal dilation. Our next focus is on hiatal hernia. Diaphragmatic hernias result from weakened diaphragm. They are very common, affecting 40% of the population. A protrusion of the part of the stomach through the diaphragm into the esophagus results. Types of hiatal hernias include sliding hernias. 90% of hiatal hernias are sliding hernias. Esophagogastric junction and part of the fundus slide upward into the thorax. The hernia slides freely up and down into the thorax with changes in intra-abdominal pressure or position changes. Most frequently occurs when person is supine. The next type of hiatal hernia, rolling or paraesophageal hernia. In this condition, gastroesophageal junction remains in normal anatomic location, but the fundus rolls upward into the thorax, forming a pocket alongside the esophagus. There's less reflux because the lower esophageal sphincter remains in place. There's a higher risk of volvulus obstruction and strangulation. Hiatal hernias due to conditions that increase intra-abdominal pressure, and some of those conditions that lead to increased abdominal pressure include obesity, pregnancy, and aging. Assessment and intervention. Primary symptom, heartburn. Heartburn worsens following large meals. Vomiting and abdominal distension may occur. Interventions and assessment. You want to offer small meals and bland foods. No smoking, and to avoid tight clothing. Avoid straining, which can lead to coughing and bending. Elevate head of bed 4 to 12 inches. Surgical correction usually becomes necessary unless pregnancy related. The next condition, gastroesophageal reflux disease, also known as GERD. In this condition, you have a flow of stomach acid up into the esophagus. The lower esophageal sphincter closes too tightly. It results in burning pain behind the sternum. Symptoms worsen after meals, and GERD can be seen in hiatal hernia. Signs and symptoms: heartburn, painful swallowing, water brash or salivary hypersecretion in response to reflux. Pain may radiate up to the jaw, neck, and back. Regurgitation, which leads to a bitter taste in the mouth. Dysphagia, bleeding, aspiration can occur, scar tissue due to inflammation, and they may have nocturnal cough, weakness, and hoarseness. Treatment: they need to change their lifestyles. Stop smoking if they smoke, lose weight if overweight, and avoid problematic foods. Antacids will be used to elevate the pH of gastric secretions. Medications commonly used include Maalox and Mylanta. H2 receptor antagonists that may be ordered include Peptic, ACUTE, Tagamet, and Zantac. Protein pump inhibitors that may be ordered include Protonix, Prevacid, Prilosec, Nexium, Acifix. Protective agents that may be ordered include Carafate. Pro-motility agents work to increase gastric emptying and include Reglan. You need to look up each of the aforementioned medications and know them in detail. Treatment and continuing, you want to have the person to consume small, frequent meals. A low-fat, adequate protein diet. They should avoid caffeine, chocolate, milk, and spicy foods, which can aggravate the problem. Eliminate alcohol. No smoking, and they may have to have surgery. Nursing management, providing education to the patient about foods and other activities that should be incorporated into their lifestyle and other changes that they need to make. Sleep with head of bed elevated 6 to 8 inches. Avoid lying down 2 hours after eating. Avoid late night meals. Eat slowly. Chew foods thoroughly. Maintain ideal body weight. Avoid foods that irritate. Take medications as prescribed, and do not stop the medications prematurely. They need to take them until the duration is stopped by the doctor and as ordered. Avoid heavy lifting and bending. Gastritis is the next condition. It involves inflammation of the stomach lining. It's due to irritation of the gastric mucosa. Typical causes include nonsteroidal anti-inflammatory drugs, smoking, alcohol, burns or surgery, which are physiological stressors, chemotherapy, food poisoning, bacterial, viral, chemical toxins such as H.PYLORI, excessive aspirin, and caffeine intake. Gastritis is most prevalent disease affecting the stomach. It is available in acute and chronic forms. Please read about both. Signs and symptoms: epigastric pain, nausea and vomiting, fever, if bacterial in origin or viral in origin, anorexia, diarrhea, and you want to observe for gastric bleeding such as melena or hematemesis. Acute gastritis, usually benign, self-limiting condition. Treatment may involve the use of antibiotics if it's bacterial in nature, antiemetics, antacids, H2 receptor blockers, IV fluid and electrolyte replacement therapy. Chronic gastritis is a group of disorders with progressive and irreversible changes in the gastric mucosa, more common in the elderly, chronic alcoholics, and smokers. Symptoms of chronic gastritis include feeling of heaviness in the epigastric region, gnawing, burning, and ulcer-like epigastric pain, unrelieved by antacids. Pharmacological treatment for gastritis: NPO 6 to 12 hours to allow GI tract to rest. Slow reintroduction of fluids. Begin with clear, then full liquids, then food. Monitor the intake to see how well they are tolerating that food. Peptic ulcer disease is an ulceration of the mucosal membrane or deeper structures of the GI tract. Peptic ulcer disease most commonly occurs in the stomach and duodenum. It is found more commonly in men, increasing among the elderly due to their excessive ingestion of NSAIDs. Gastric ulcers. Here you see two pictorial illustrations of stomach ulcers. Peptic ulcers may be caused by NSAIDs, excessive amount of gastric acid, decrease in mucosal resistance, infection with H.PYLORI bacteria. Gastric ulcers are more common in women, peak age 50 to 60 years. It's associated with smoking, H.PYLORI infection, NSAIDs, and alcohol use. Pain occurs 1 to 2 hours after eating. High recurrence rate is seen. No evidence that shows link to ingestion of spicy foods. Duodenal ulcers, more penetrating type of ulcer, associated with increased production of gastric acid. More common in men 35 to 40 years and is associated with stress. Pain occurs 2 to 4 hours after eating and is relieved with antacids and food. High recurrent rate. Duodenal ulcers are more common. More perforations are present with duodenal ulcers, but higher mortality rate with perforation of gastric ulcers due to older age of the patient. Stress ulcers. About 1/3 of all ulcers are stress ulcers. They develop in response to a major physiologic stressor, especially with burns and major surgeries. They may be due to ischemia with blood being shunted away from GI tract during physical stress. Signs and symptoms of peptic ulcer: aching, burning, gnawing, pain in the epigastric, pain more on empty stomach in middle of the night, nausea, eructation, bloating, hematemesis, melena, may get perforation and gastric outlet obstruction. Therefore, you need to be monitoring the patient and making them aware of those signs and symptoms so that they can monitor themselves when they are not in the clinical or hospital setting. Peptic ulcers may lead to bleeding, as stated, or perforation. Both are emergency situations. Treatment for H. pylori involves triple, dual, or quadruple therapy. Triple therapy includes the use of proton pump inhibitors, amoxicillin, clarithromycin, all for 7 days. Dual therapy, Tritec or bismuth citrate, clarithromycin, both for 7 days. Quadruple therapy, proton pump inhibitor, bismuth, tetracycline, and flagyl, all for 14 days. Each of these medications are to be looked up and you be thoroughly knowledgeable. Pharmacological treatment for peptic ulcer disease includes antacids, which will neutralize the acids. Examples: Maalox, Toms, Mylanta. Histamine H2 receptor blockers block secretion of acids. Medication examples: Pepcid, Tagamet, Zantac, Axid. Protein pump inhibitors inhibit secretion of acids. Examples: Prilosec, Prevacid, Nexium, Protonix. Mucosal barrier agents adhere to the ulcer. Example, sulforaphate or caraphate. Lifestyle modifications with peptic ulcer disease. Stop smoking. Decrease or eliminate caffeine. Avoid alcohol. Avoid irritating foods. Small frequent meals. Complications if an ulcer should occur include hemorrhage and perforation, which can lead to peritonitis, and both of these are emergencies. Obstructions can occur. Let's look at hemorrhage first. Bleeding due to ulceration and erosion into the blood vessels. Small blood vessels, if involved, have a slow blood loss and it is insidious. Occult blood in stool. Larger vessel involvement, the person can bleed out, have frank hemorrhaging. Perforation as a complication is the most lethal complication. Gastric content enters into the peritoneal cavity. Immediate chemical peritonitis occurs, then bacterial peritonitis within 6 to 12 hours. With perforation, you will see immediate severe upper abdominal pain, abdomen rigid and board-like, absent bowel sounds, signs of shock. NG tube is inserted to decrease spilling of gastric content into the peritoneum. They need replacement of lost blood volume. Therefore, the person may have packed cells ordered or whole blood. Requires surgical closure of perforated area. Obstruction as a complication is due to edema around the ulcer. Is due to smooth muscle spasms or scar tissue formation. A gradual rather than an acute process is seen with an obstruction. Requires NG tube and decompression of the GI tract to allow the GI tract to rest. Surgeries for ulcers. Antrectomy involves removal of the antrium of the stomach. Gastrin producing portion of the stomach is removed. Gastroduodenoscopy, which is known as a BROF 1, involves fundus being anastomosed or attached to the duodenum. Gastrojejunostomy is a BROF 2. This surgical procedure involves closure of the duodenum. The fundus is anastomosed to the jejunum, mostly done for cancerous conditions. Total gastrectomy, removal of the entire stomach. With a vagotomy, you have removal of the vagal innervation to the fundus, which decreases acid production by parietal cells of the stomach. Gastrectomy. Here you have a picture showing part or all of the stomach removed, intestine anastomosed or joined to the stomach. Here's a before and after picture of the gastrectomy. Post-op complications, dehiscence, eviscerations, diarrhea, pernicious anemia, which is a deficiency of the intrinsic factor, and as a result, the person will most likely be on vitamin B12 for life. Iron deficiency anemia, impaired absorption and rapid emptying of stomach leads to this condition. Hemorrhage, dumping syndrome. Because you have had a segment of the GI tract removed, you have food going much faster and liquids faster through the GI system. So the food just dumped from one part to another because you've had a portion removed. Dumping syndrome, direct result of surgical removal of large portion of the stomach and pyloric sphincter. It involves rapid gastric emptying and increased intestinal motility. Palpitations and sweating can be experienced by the patient, as well as faintness, weakness, and dizziness. Explosive diarrhea or vomiting. Nausea, epigastric pain, borborygmy, and dyspepsia. And with borborygmy, you will have an increase in the bowel sounds. You don't even have to have the stethoscope in place on the abdomen. Treatment: 6 small meals a day. High protein, high fat, low carbohydrate diet. Person should eat slowly, avoid liquids with meals. Anticholinergic agents are given to reduce stomach motility. They should recline 1 hour after eating. Another surgical procedure for GI disorders: gastric bypass surgery. Most commonly used bariatric surgery, also called Roux-en-Y gastric bypass. With this procedure, you have gastric resection plus malabsorption surgery. A portion of the client's stomach, duodenum, and jejunum are bypassed so fewer calories can be absorbed. Post-op complications of gastric bypass: special bariatric considerations post-op. You want to have the person on a special bed or wheelchair, and those items are usually ordered in advance. And you need to have those considerations for home placement as well. Client may have NG tube. Never reposition NG tube because it can disrupt the suture line. The doctor should be called if you see any problems with the NG tube. Diet is advanced slowly. Clear, pureed, then 6 small regular meals. Again, monitor their dietary intake and tolerance level. Use abdominal binder to prevent wound dehiscence. Monitor for dumping syndrome. This ends the presentation, and I look forward to your involvement in the case studies and open discussion of these conditions of the GI tract. And I know we did not have on this slide, but in your text there's information on E. coli, salmonella, and the other disorder. Thank you.